They're the movers and the shakers. They're the ones who change our world. And they deserve places designed especially for them, built with kids' specific needs in mind. The latest technology in the caring hands of our dedicated pediatric specialists and primary care physicians, helping kids feel like kids. St. Tammany Parish Hospital, world-class health care for children close to home.
Hello and welcome to Healthy Living, brought to you by St. Tammany Parish Hospital. I'm your host, Christian Moises. We're in August, which means it's National Prostate Cancer Awareness Month. And to talk a whole bunch about the signs and symptoms and what you need to know is Dr. Jack Saux, medical oncologist with Northshore Oncology Associates. Dr. Saux, thanks for being here today.
Thank you for having me.
You know, and one thing real quick I want to throw in there is congratulations again on being named one of the North Shore's best when it comes to oncology. So
thanks a lot.
We got a double duty here. With Prostate Cancer Awareness Month, of course, we want to get the facts out there. And if you could kind of give us a real quick rundown of some of the important things people need to know about prostate cancer.
Prostate cancer occurs in men over 50. Very rare to be under 50, and average age is in the mid-60s. There are a few symptoms to kind of be aware of, and that's changes in your urinary stream and difficulty urinating, frequent urination at night, erectile problems, and blood in your urine. If any of these things start to occur, you should follow up with your primary care doctor or urologist.
Right. Now, what are some of the risk factors in terms of hereditary factors and whatnot that may lead to prostate cancer?
Prostate cancer seems to run in families, but we don't have a definite genetic link. It's more common in African Americans and less common in Hispanics and Asians. It's the second leading cause of death from cancer in men in the United States.
And it seems to be becoming more and more common. I hear more and more cases of prostate cancer out there. Is that the case?
I think it's probably a result of the screening that we're doing now, and we're picking up cases earlier. So there's more, the number is increasing.
Right. What, you know, if somebody out there is watching and they are over 50, what are some of the concerns that you hear from patients when they come to you? What are some of the common questions that they have?
Well, by the time patients see me for prostate cancer, usually further along. Mm-hmm. But in general, men are concerned at age 50, they know that they should go and have a prostate exam by a urologist when they turn 50, and then yearly after that. Concerns about how aggressive a prostate cancer might be are also raised sometimes, but most prostate cancers are pretty slow growing. There are aggressive forms, but really early detection is the key to beating this.
Now, and prostate cancer is it easily treatable?
Initially, prostate cancer is treated with a combination of surgery and radiation, and there's several different types of radiation delivery systems that are used. Prostate cancer is then treated, if it's not completely eradicated with those procedures, with hormone manipulation. After a period of time, if hormone manipulation fails, then chemotherapy and some new targeted drugs for advanced prostate cancer are used.
Okay. Can you walk us through a couple of those radiation therapies that you were talking about?
They have external beam radiation where the radiation is delivered through the body, and then they have radiation seeds that are implanted by the surgeon into the prostate. And then they also have a different therapy, brachytherapy, where other radioactive rods are placed in the prostate for treatment.
Okay. You talked a little bit about screenings, and screenings with any cancer are always important. What is the success rate in treating prostate cancer if you find it in a screening?
If you find it early, and depending on the grade of the cancer, it can be very good. It's very complicated the way that prostate cancer is graded, and so to give a blanket statement of early detection is going to lead to a cure is inaccurate.
Right.
But it does definitely improve the prognosis.
What is prostate cancer? We talked about it being pretty prevalent. It's the second highest cancer out there, second deadliest cancer out there. How big of a problem is it in St. Tammany Parish?
It's common, and as the population of the parish ages, we're going to see it more.
Right.
In general, St. Tammany Parish has been a relatively young parish, but the population is aging, and we're going to start to see more incidents of it.
So it's important to get those screenings. You turn 50, make sure you go in to see your physician. Any of those warning signs, make sure you get it checked out as soon as possible.
Absolutely.
So, well, Dr. Saux, thanks so much for being here with us. I appreciate it. And when we return, we'll be talking with Dr. Sunil Purohit.
For the best possible results, how far would you travel? Would you take an international flight to find a hospital that ranked among the very best in the world for the treatment of heart attacks? For the best possible results in 9 cardiac care measures, just how far would you go? St. Tammany Parish Hospital, world-class healthcare, close to home.
Welcome back to Healthy Living, brought to you by St. Tammany Parish Hospital. We're talking all about National Prostate Cancer Awareness Month, getting you the facts, and now we're joined by Dr. Sunil Purohit, a urologist for Purohit Urology, a division of Louisiana Healthcare Associates. Dr. Purohit, thanks so much for being here.
Thanks for having me, Christian.
You know, we just had a great conversation with Dr. Saux about some of the signs and symptoms, facts about prostate cancer. And one of the things that we were talking a lot about were the screenings. We actually have a couple of those coming up this month and into September. But I know that you wanted to talk a little bit about the importance of screenings.
Yeah, you know, Christian, one of the big topics in the past year, couple of years actually, has been, you know, screening for different types of disease processes. And prostate cancer keeps coming up because majority of prostate cancer is not the aggressive form. In fact, by the age of 80% of males have prostate cancer in their prostate. Now, not all of them are diagnosed,
right,
because they're not symptomatic, and they may go their whole life, and they usually do, without any problems. The goal of the screenings are to target those people who lives can be affected by prostate cancer. And usually it's going to be people with family history of prostate cancer. They usually have the more aggressive form. And also African Americans. And you usually will see the underprivileged. They're the ones who will usually show up. You know, Dr. Saux was talking about some of the signs and symptoms. You know, burning, you know, problems urinating or bleeding in the urine. Those are patients that will show up in the ER with those symptoms, and then a lot of times there's not much you can do except palliative measures. So we want to target those people. We want to get them in those screenings. We want to catch this stuff early. And you know, if you catch it early, prostate cancer is very treatable.
Exactly.
And you can, follow these patients for years and they'll have no issues. But you know, once the cat's out the bag, so to speak, and you have metastasis or spreading of the cancer to bone or lungs or what have you, then, you know, it becomes more of a difficult situation.
Right. Tell me a little bit about kind of what a screening entails.
Well, basically, there's 2 parts to a screening. The digital rectal exam, which is the finger wave, so to speak, where we kind of palpate the prostate and just kind of feel the surface. We want to make sure it has a nice smooth consistency. There's no hard nodules or irregularities. And then also the PSA, the prostate specific antigen, which is a blood test. And basically, there's a lot of talk about the PSAs over reaching as far as leading to too many unnecessary procedures, because it's a sensitive test. That means it will catch majority of cancers, but it's not specific. So a lot of people with elevated PSAs can have that due to other reasons. You know, there's patients who have prostate infections, who, you know, a lot of times you'll find patients who do a lot of bike riding, they'll have an elevation because the prostate's being irritated continuously. So, you know, you have to look at the whole picture. You have to look at the patient's, you have to do the exam and the PSA, and then see, you know, even velocity. How quick is the PSA going up or down? So a lot of factors, you know, play into, you know, evaluating a patient for prostate cancer.
Well, Dr. Saux was talking about being a medical oncologist. He sees these patients when there's a serious problem.
Right.
You're seeing them more on the front end with your practice as a urologist. Tell me a little bit about your practice and kind of what you're seeing on the front lines.
Sure. Well, you know, as far as, you know, my practice, I practice general urology, and so we do everything from treating kidney stones to all different types of cancers, whether it be prostate cancer, you know, kidney, bladder cancer, testicular cancer, and also we do a lot of incontinence procedures for, you know, for leakage. It's very common in women, and we're able to treat those with minimally invasive techniques. Now we've kind of veered towards a lot of minimally invasive surgery, and that's where urology is going. So we're able to do anything from prostate cancer surgery to kidney cancer surgery to prolapse, vaginal prolapse surgery. Anything, I would say majority, maybe 80 to 85% of urology now can be done, you know, minimally invasively. When I mean that, you can do a big surgery through small incisions. And now, you know, at St. Tammany Hospital, we have the Da Vinci system, which has really made things, we have advanced so far. A lot easier. And patients are staying in the hospital in much shorter periods of time. They're able to leave within 24, 48 hours, much less pain, and they're back to doing their routine activities much quicker. And so it's a win-win for everybody.
Right. And we're going to talk about the Da Vinci when we come back from a break in a little bit. But I wanted to get back a little bit to what you hear from patients. What are some of the big concerns that you hear, a lot of the questions that you'll get? I'm seeing this or I'm feeling that. Kind of walk through what a day in a patient visit is like.
As far as prostate cancer?
Exactly.
Yeah. So basically, majority of my patients are going to come in for routine screening. So generally, you know, they may have mild symptoms of, you know, as you get past 50, you're going to have some issues here and there with voiding, because, you know, in males we have this thing called the prostate, which is really a reproductive organ. It's there to give nutrients to the sperm.
Right.
You know, so you can have good healthy sperm to have babies. But after that, it's more or less a nuisance. And so patients will usually come in for screening. Now we make sure that the patients are voiding well without any problems. We check their urine, make sure there's no, you know, blood in the urine, no bacteria, no infection, and then we do an exam. And again, we look for those things we mentioned earlier, as far as consistency of the prostate, and, you know, we kind of size up the prostate, so to speak, and we do a PSA, and so we get that way you get a full idea of, you know, how the patient is doing as far as you know, the prostate goes.
Right.
Now, if the patient has an elevated PSA or an abnormal exam or both, then the next step is to do a biopsy. And that's an office procedure. It's basically the patient is given a local anesthetic, and we do an ultrasound-guided biopsy. We go transrectally, and we take samples of the various areas of the prostate and send it to the pathologist, and they tell us, hey, listen, you know, this gentleman's got this grade cancer, this is the volume, and they're able to give us an idea of the positive cores. And so we can kind of make an educated assessment of, you know, the volume of cancer and how aggressive it is.
Right. You know, and you just mentioned again about the grades. And I kind of wanted to dig into that in case somebody gets a different level, you know, so they can understand where it stands on the scale. Dr. Saux talked about it a little bit too. What are the different grades when it comes to prostate cancer?
Well, we use what is called a Gleason's scoring system. And so what happens is, say you have an area of cancer. The pathologist, depending on how differentiated the cancer is, they look at the cells and how aggressive the cells look. They will score it from a 1 to a 5, 5 being the most aggressive, 1 being the least aggressive. And then they look at a second area in that sample, and they grade it 1 to 5. So you get the most common cells, then you look for the second most common cells, and then you have a total score. So for example, if you have a patient who has the most common cells are a grade 3, you have and the second most common are a 4, you have a 3 plus 4 equals 7. Okay. Now 3 plus 3 or 6 is the most common. And that's the run-of-the-mill, non-aggressive, middle-of-the-road prostate cancer. Once it starts getting into the 3 plus 4, the 4 plus 4, any of those higher grades, you have to be a little bit more,
aggressive with it.
Aggressive, exactly. So nowadays, we're doing, for a lot of patients now who have 3 plus 3 low volume prostate cancer, which is fairly, not that aggressive, you can actually do what we call active surveillance. So in other words, they come at 6-month intervals, I do exams, we do PSAs. We just want to see that everything's stable. They may go their whole life without having any issues because, again, we are trying to get those patients out of the treatment protocol because studies are showing that those patients can go their whole life without having to undergo any treatments, which means less issues with morbidity from the treatment processes, which include incontinence or impotence, those things. So.
And once treated for prostate cancer, is the remission level pretty low? Is that, I mean, of course it depends on the patient and the cancer, but for the most part, would you say it's pretty much once and done?
As far as the treatment?
Exactly.
Yeah. If you have localized prostate cancer, say a patient comes to me for a robotic prostatectomy, we're able to now, treat the cancer. Number one, that's the first goal. And also the incontinence is minimized because we're able to use the Da Vinci, the robotic prostatectomy technique, where we can spare the nerves that are important for erections, and also we're able to spare the urethra, which is important for the incontinence.
Exactly.
So you're getting it, like again, you're catching it early, and you're treating the cancer, but you're keeping the quality of life in place, which is very important, of course.
Right. Dr. Purohit, this is some great stuff. When we return, we'll be talking with Dr. Purohit about the awesome and cutting-edge procedures he's doing with these robotic procedures at St. Tammany Parish Hospital.
Which flavor? There's no right or wrong answer. The options are endless and can be as unique as our personalities, be it young or not so young. And when it comes to your family's primary care doctor, we believe you should have plenty of choices too. Exceptional care, custom made for you. Because living here means getting condensed milk every once in a while. St. Tammany Parish Hospital, a world-class physicians network close to home.
Welcome back to Healthy Living. We're talking with Dr. Sunil Purohit all about prostate cancer, and we're going to move into a cool segment talking about the robotic procedures he's doing at St. Tammany Parish Hospital, specifically with the Da Vinci system, and a cool new procedure you're doing called that you're using the Firefly fluorescent imaging coupled with the Da Vinci to really improve the accuracy and recovery time. Tell us a little bit about what exactly this procedure is and what it's doing to revolutionize the process.
Well, for Firefly, its mainstay in urology has been for what we call for partial nephrectomies. So that means nowadays all the studies are showing that, if someone has a tumor in their kidney, there's not necessarily a need to remove the whole kidney. In fact, as patients are living longer, people are living in their 90s nowadays, and they can use as much of the kidneys they can have. So in other words, we don't want to have people having to have issues with with kidney problems in the future where they need dialysis, etc. So why don't we find a way to be able to remove the tumor and spare the kidney and do it in a minimally invasive fashion. That's how Firefly came about. And basically it's a fluorescence imaging which is connected to the robot. And so we're able to robotically remove the portion of the kidney that has a tumor with the margin of normal kidney. And the Firefly, what it does is, it's injected, the anesthesiologist injects it intravenously, right into veins, and all the normal tissue would light up green. And actually, it's almost like having a quote-unquote like a black light that you can kind of turn off and on. And actually, we had a nice video, but it's just a little too graphic for the audience. But it's really cool to see because the kidney, the normal tissue will light up, a nice bright green. And you're going to have the tumor, and a little bit of the surrounding tissue is going to not light up at all. So you kind of have an idea where you have to go to cut the tumor off and keep a margin of normal kidney.
Right.
So with the use of St. Tammany, we have an intraoperative ultrasound machine, Laparoscopically, we are able to kind of look at the kidney tumor and mark it off where we want to cut. Then we inject the Firefly in, and under visualization, we can actually, with confidence, cut the tumor with a margin of normal kidney, and then you sew everything back up. You close the kidney back, and we can do that robotically because we have those fine instruments that are able to, precisely put stitches in blood vessels and in the tissue, and then, have the patients go home within a 24 to 48 hour period.
And the procedure time too is also cut down to hour and a half, 2 hours. Exactly. You're in and out. Whereas laparoscopy, you would be in for
4 hours.
4 hours. The recovery time, you got the scars, you got a couple of days in the hospital to recover. This is making an in and out service, and very minimally invasive.
Yeah, and I tell patients, they ask me, well, what's the difference between doing it laparoscopically and robotically? Robotic surgery is a form of laparoscopy. You're going through small incisions. The difference is when you were just doing it laparoscopically, it's like working with chopsticks. With robotics, you're working with chopsticks with hinges at the end. Right. So it's almost like a normal hand motion. You have wrist motion and finger motion, so you can get behind in tough spots and close blood vessels. You can sew everything up much easier, and then you have the advantage of having a 3D image. So it's almost like being in somebody's abdomen, right. Going around in their belly, dissecting all this tissue out. So it's been amazing how technology has advanced in the past several years.
Yeah, we're actually showing some cool videos right now of the machine doing origami and actually peeling the skin off of a grape to show just how detailed and how spot on these hinges that you were talking about are when they're in the procedure. Yeah. What else are y'all using the robotics for in these surgeries?
Well, any surgery that requires reconstruction it's an ideal surgery for robotics. So in urology, our big surgeries, for radical prostatectomy, where we take the prostate out for cancer. With the robot, again, as I mentioned before, we're able to take the cancer out with the prostate, and are able to spare the nerves because you have such a nice view and you have a bloodless field compared to open surgery. You can spare the nerves that are responsible for erectile issues, and also you can spare the urethra because you're doing such a precise dissection where patients will recover their incontinence issues much quicker. So they won't have to wear pads and diapers or etc. for a lengthy period of time because all that is returned. Right. So that's a huge advantage. And that's where it really started getting very popular. Then we started doing it in kidneys for the partial kidney removal. I even use it for total kidney removal when I have to at times because again, it's such an easy way to do it, and the patients do so easy with it. They recover so easy with it. And there's another procedure which is very common in our population, especially in the elderly population. It's called vaginal prolapse, where basically, a big portion of the vagina, as the pelvic floor ages and gets weakened, it will, drop out. And, older patients, the only options they really had for this were, a pessary, which is like a device which is placed in the vagina, which you have to pull out periodically to wash and return, and that's what they would use to keep everything in position. But yeah, and then the other option would be open surgery. It's called a sacrocolpopexy, where we take the vagina and suture it back to the sacral promontory, the sacrum bone, to bring everything back to its normal position. That was a morbid procedure because patients, would have a big incision. They'd be in the hospital for 3 or 4 days. Even for the younger patient, it's a tough surgery. You can only imagine how tough it was for the older patients. So now we're able to do this all robotically, and they're going home and within a 24-hour period. And so I've noticed in my practice that has increased quite a bit. And so I'm having a lot of these patients in their 70s and 80s who are coming in. They're saying, listen, I don't want to do the temporary fix with the pessary. I want to go ahead and have the surgery, and they're doing really well with it. So that's another big procedure. Lastly, pyeloplasties. There's a thing called a UPJ obstruction where the ureter and kidney meet. There's a lot of times patients will have a stricture. And it can be, a congenital thing, and it can be acquired thing. Again, that would require a big flank incision in the older days to take that stricture out and reconstruct, suture back the ureter and the kidney. Now we can do it robotically, and instead of having a 3 or 4 day hospital stay, patients are going home in 23 hours.
And the incision size is, going from a couple of inches to a couple of centimeters?
Right, that's it, I mean, so now you just basically, usually you have 4 or 5 incisions that are, basically, half an inch
Right.
in size, compared to in the old, I'm sure a lot of the older patients who've had kidney surgery or whatever, they'd have a big flank incision.
Right.
I mean, you're talking about incision about this big, going almost halfway across your flank area, and you're going through muscles, and I mean, it takes a lot of time to heal from that.
Right.
With this stuff, it's so much quicker, and you're getting this, the results are equivalent, if not better.
And coming full circle, going back to prostate cancer, robotic surgery is becoming, or is the gold standard right now for that.
Absolutely, yeah. I think right now, if you look universally now, even worldwide, the Da Vinci prostatectomy compared to open surgery is definitely becoming the gold standard. And so, in other words, if there's a robot available in a community, majority of the patients who are going to have prostate surgery in that community are going to have it with the robot.
Well, good to know. And we just have the most recent one at St. Tammany Parish Hospital, so we're always glad to have you come by the hospital and knock that stuff out. So
I appreciate it.
Dr. Purohit, thanks for being with us today.
My pleasure.
Thank you for watching, and we'll see you next time.